Hi, everyone, and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenauer, and today I'm joined by adult post-intestinal transplant physician assistant at MedStar Georgetown Transplant Institute, Hannah Sagedy. We're discussing small bowel health. We'll be talking about the vital role your small bowel plays, how to know if something's wrong, treatment strategies, what conditions would lead to needing a transplant, and more. We're also joined by Katie Silva-Mendez, who is a patient with us and a recipient of a small bowel transplant, and she's here today to share her story. So if you'd like to learn more, then stick around. Give us a like to let us know you're watching and share this broadcast with your friends. And as always, if you have any questions for Hannah or Katie, you can ask them in the comments below. So Hannah and Katie, thank you and welcome. We appreciate you all being here today. Before we begin, Hannah, could you tell our viewers a little bit about yourself and the work you do at MedStar Health?
Sure. So thanks for having me today as well. Again, my name is Hannah Sagedy. I'm a physician assistant at MedStar Georgetown Transplant Institute, and I specifically and primarily work on the outpatient side for patients who have received an intestinal transplant. And I've been working at Georgetown for the past 6 years.
Great. Well, thank you again for being here. And Katie, could you tell our viewers a little bit about yourself and what brought you to MedStar Georgetown Transplant Institute? She came all the way from Nevada, so that's a long ways to travel.
It is, yeah. I'm Katie. I had Crohn's disease for 14 years now, so I needed a transplant, and came from all the way from Las Vegas to DC. That's why I'm here.
Awesome. Well, thank you. So let's get into the questions now. I'll start off asking Hannah, what is the small bowel, and what does it exactly?
Yes, so the small bowel, you also may know that as the small intestine is a part of your gastrointestinal system or digestive system, and it's connected with your stomach and your large intestine, which you may also know as your colon. And so the main role of the small bowel is absorption of nutrients. And we can break the small bowel into 3 different sections. The first is the duodenum, the jejunum, and the ileum. So the first part, the duodenum, is where food from the stomach comes down and is being further broken up by pancreas enzymes and gallbladder bile, and then moves on to the second part, which is the jejunum, which is where a lot of nutrients are being absorbed into your bloodstream, such as nutrients like carbohydrates and proteins. And then it further moves down into your ileum, which is the last part of your small bowel. And this is where nutrients that were not already absorbed in the jejunum are being absorbed into the ileum and again into your bloodstream, such as vitamin B12. And in the small bowel, you have what are called these villi, which are these finger-like projections. So if you can imagine just like a tube, which is your intestine, you have what's called the villi, and they're sticking up like this, and they just increase the surface area of the bowel and then maximize the capacity for absorption of these nutrients. And I know you didn't ask me specifically about the large intestine, but just to throw that in there. So the large intestine's main role is for absorption of water and getting rid of that waste. And fun fact is that the small intestine is actually longer in length than the large intestine. So the small bowel is approximately on average like 26 feet versus the large intestine, which is around like 5 feet. The large intestine gets its name because it's actually like wider in diameter than the small bowel. So though both are very important, the small bowel is actually plays the greatest role in the absorption of nutrients.
Great, thank you for explaining that. And yeah, as soon as you said that, I was going to ask, now why is it called the small bowel if it's bigger? But that makes sense. So my next question is, what is intestinal failure?
Sure. So intestinal failure is when there is an inability for your intestine to absorb those nutrients properly. When this happens, many patients will require what's called TPN, or total parenteral nutrition. And essentially, this is just an IV liquid nutrition that's going through the veins instead of someone eating food and getting nutrients that way and going through the digestive system. Instead, that IV nutrition is going through the veins. And TPN is made up of carbohydrates, protein, sugar, fats, everything one needs to survive. But unfortunately, patients will have to be on TPN for 10 to 12 hours a day 5 to 7 days a week. So it is pretty, strenuous on them. Another thing is that some patients will have what's called an ileostomy or a colostomy. That might be more familiar of a term for people, but this is where the intestine is surgically diverted through the abdominal wall and waste is actually coming into like a pouch or a bag instead. And that's basically what we see with intestinal failure.
And if I can chime in with TPN, I was actually personally, I was on it 24 hours a day. It was nonstop. I had to get my vitamins, all of my nutrition through there, just because I had so much stricturing to where no food would pass through. And then my intestines were failing, so nothing was really moving. There was not a lot of mobility. And I had an ileostomy going into this. It was a permanent an ileostomy. But yeah, it's kind of like they go together in a way, but TPN it saved my life. It really did. It was just the only thing that I had left, to keep surviving. And I was on it for 2 years before transplant.
Wow. That's a long time to be on that, but like you said, it saved your life, so it was worth it. So next, I wanted to talk about what types of symptoms patients may experience. Hannah, if you want to answer, and then Katie, you can kind of talk about the ones that you experienced too.
Yeah. So again, everybody is different, but generally speaking, patients will have, they can have high ostomy output, so a lot of fluid from that stoma, or diarrhea. They can have abdominal pain, discomfort, bloating, cramping, weight loss, or even to the point of malnutrition.
Now, personally for me, when it came to symptoms, it was exhaustion, just pain, constant pain all the time. I was with the diarrhea, I was using emptying my ostomy 40, I think it was like 40 plus times a day. I mean, it was just everything that went in me was going straight out. But by the time I got to Georgetown, I only had 6 feet of small bowel left. I had no large intestine at all. So, and in 28 surgeries just leading up to it, but that's all I had left. So everything that would go in would come right out. But a lot of bloating, pain, cramping, and with strictures, not a lot of movement. So, you have anything from bowel obstructions to just kind of like a wide range of of symptoms that happen when it gets down to that part.
Wow. And so talking about this, are there different types of intestinal failures that can happen, or is it all just, one type?
Yeah, so I can basically break it up into 2 different categories. The first is what we call short gut syndrome or short bowel syndrome, and this is where the bowel is physically shorter in length. As Katie was mentioning, she only had 6 feet left. So again, this is just much shorter, and then the bowel is unable to absorb those nutrients that you need. So for examples of why this happens is, severe Crohn's disease is one. Another is if there's an issue to the blood flow to the bowel. So say there's a clot in the blood supply, or there's a twisting of the bowel, such as like a volvulus. If patients have abdominal surgery complications, or any kind of tumors involving the intestine, that can be why that's happening, where it's physically shorter. The second is what we call functional disorders. And this is where there is enough length of small bowel. It's just that the small bowel is not doing what it's supposed to do. It's either not moving or absorbing properly. And for these, like an example of this would be, there are a variety of dysmotility disorders, but we have one called chronic intestinal pseudo-obstruction. And this is where patients feel like the intestine is mimicking having an obstruction or a blockage when there actually isn't physically that happening, but they'll have the symptoms of that. Another would be for patients who have had cancer in the abdominal or pelvic regions. If they're as part of their therapy for cancer, the bowel after that may be affected from that and not work as properly as it did before.
Okay. And so what is intestinal rehabilitation? Katie, is that something you had to go through? Could you explain what that is first, and then
Sure.
Katie, you can talk about it too.
So intestinal rehabilitation is where we use different methods to rehab the gut. So we want to make the remaining gut as functional as possible. We can do this medically and surgically. So medically, we can use different medications. As Katie was saying, she was having a lot of high output. We can try to use different medications to slow that down. We can also use other prokinetic drugs, such as, making the bowel motility improve. We also have hormonal therapy where that helps the absorption of the bowel that's remaining increase. And then we also have dietary changes. So certain foods can trigger certain symptoms. And then finally, we do have surgical, like rehabilitative surgeries. And again, this is just to promote the remaining function of the bowel to optimize that. Here at MedStar Georgetown, we have a dedicated gastroenterologist and dietitian that can help optimize the IV nutrition as well as the medical management. And then we also have a dedicated surgical team. The first step for intestinal failure is intestinal rehabilitation. And then if that fails, then the next step would be that you may be a candidate for intestinal transplantation.
That answered my next question. So it works out. So Katie, can you talk about your, experience with this?
For me, it was, we really did try to get what intestine I had left to be able to rehabilitate it. At that point, I needed transplant. By the time I got to Georgetown, there was really not a lot they could do. It was more just get me healthy enough to have transplant. And like she said, with those medications to slow down the output, I kind of was on bowel rest with being on TPN 24/7. So I was just there. I did have like a form of the intestinal rehabilitation, just not the extent that some other people could.
Okay. And so, like you said, that's the first step is rehabilitation, and then you find out if you're a candidate for a transplant. So can you talk about what is an intestinal transplant? Like, how does it work? That sort of thing.
Yeah. So quite simply, it is the replacement surgically of the small intestine, and this can include a colon or not. And it is going to be from a deceased donor. So simply your small bowel is taken, colon if you have it, rarely, is replaced, and then we put in a donor intestine and colon.
Okay. And you said it can't be a living donor. It's
no, it's all deceased donor.
Right. Okay. So next we're going to talk about, what the indications of a small bowel transplant is needed, what those signs might be. But first, I want to say, if you're just now joining us, thank you for tuning in. We're speaking with adult post-intestinal transplant physician assistant Hannah Sagedy about small bowel health. We're also joined by Katie Silva-Mendez, who is a patient with us and a recipient of a small bowel transplant. And she's here today to share her story and her experience at MedStar Georgetown Transplant Institute. So we have a lot more to talk about, so stick around. Give us a like to let us know you're watching, and share this broadcast with your friends. And of course, if you have any questions for either Hannah or Katie, please leave them in the comments below. So like I said, what are the indications that a small bowel transplant would be needed?
Right. So the reasons we transplant patients are because of complications, and these complications arise from the TPN that patients are reliant upon. So again, the IV nutrition has to go through the large veins in your body, and over time, those veins can become damaged and they can, cause clots. And when that happens, then patients start to lose access to the veins, and then, eventually can lose access to receiving nutrition at all. So that's number one. If patient is having clots, losing access, that's a big worry. The second reason would be infections. So you have an IV in, you have a direct source for, bacteria to get into your bloodstream. And if patients are, continuously getting infections, that's a big risk as well for, overall health. And lastly, the IV nutrition, unfortunately, with time, as many benefits as it does have, it can actually cause liver damage. So we don't want to cause more damage to other organs because of intestinal failure. So those are the top three main reasons that we transplant patients.
Okay. And Katie, when did you find out you needed a transplant? I know you said you went through the rehabilitation process and it wasn't working. So when did you find that out? And then can you talk a little bit about the process of actually going through and getting the transplant?
Yeah, it was about 3 years ago when I first started with Georgetown. It was 3 years ago. We tried. Long story, really long story short. Um, I was in Las Vegas and I was actually on hospice because there was just not much they could do. It was just where I was, and my friend, my best friend lives out here in Maryland, and she said, "Why don't you call Georgetown?" So I said, "Okay," and and it was about 3 years that Dr. Matsumoto and Hannah and Dr. Silva-Mendez, they really wanted me to be as healthy as possible. And I know it sounds weird to get, you're as sick as you're going, to be because you need a transplant, but they also needed me healthy enough to survive a transplant. So it was a good, 2 years of getting me as healthy as I can, getting my weight back up, getting my nutrition. I had a surgery to kind of clean out the bad parts of my intestine. It was just kind of leading up to that, and then it got down to where we all sat down and had the talk that I definitely need transplant. Like it's got to happen. I was on TPN for 2 years. It was just getting it was getting down to the wire where we just really needed to go forward with it. And I said, yeah. So it was about a few months, about 6 months before I was listed, and I think I was only listed for 4 months before I was called.
Oh, wow, okay.
Yeah.
And so what does the actual transplant evaluation involve? Hannah, if you want to talk about that, and Katie, you also can too.
Yeah. So initially you or your provider can reach out to us regarding your medical history and information, and then we can work on obtaining those significant medical records. After that, once we have this information, we'll set up an appointment for you to come here to DC to meet with our surgical and medical team. You'll undergo a series of procedures, such as if you need a colonoscopy or an ileoscopy, which again is the same thing, but just through the small intestine. Different imaging or labs, anything that we need to fully assess your medical condition. During that time, you'll also learn about the post-transplant experience and what it takes to have a successful bowel transplant. I do think that this is a pretty rigorous process for patients, as probably Katie recalls.
It is, yeah.
Patients are typically here about a week getting everything done, and it's jam-packed, but we want to keep the process moving forward. And then we ask that patients bring either a family member or a caregiver to help support them during these times. And just as a side note, we have patients from all over the country. As Katie mentioned, she was living in Nevada at the time. So again, we have patients who come from all over the country to Georgetown. We have, I think, over 20 states represented that I, help with patients, and actually 4 different countries as well. So just because you're not local to us doesn't mean that you can't come and be evaluated.
Yeah, exactly. That's a good point to make. And so, Katie, did you have anything to add for this?
The evaluation week is extremely hectic, and there's a lot. That's why it's really good to bring someone, because there's a lot of information that is just, coming at you. So it is good to have someone. I personally had like a notebook. I was writing stuff down because it's a lot of appointments in each day. But that week is probably the most hectic week you have. But it's worth every minute of it. It's worth it. But definitely bring someone with you if you can, because it's so important. If I didn't have, I would forget something, and I would go to my person that was with me and say, hey, what was that? And then they would kind of bring back, and I could always call, Hannah or someone, and they would tell me what we talked about if I had forgotten to. But
Yeah.
it's very important to bring someone with you and personally.
Yeah, it's always good to have a support system, and then it's good, like you mentioned, that you have it outside of your home as well, your personal life. You have your friends or family that can help you, but then you also have it with the doctors and physician assistants and everyone at Georgetown. That's also your support system.
Yeah, I think I called the dietitian more than I talked to my own personal doctor in Nevada. It was just
Right.
back and forth with somebody. And even if it's not their field, they still were answering and helping me. So
yeah, that's awesome to hear. My next question is about what post-transplant life typically looks like for patients. What's the recovery period like? How long before they can return home? And then, after that, what's it like post-transplant? Hannah, if you want to talk first, and then Katie, you can also talk about your experience.
Yeah. So, well, one, you'll be seeing me post-transplant. So following the actual transplant surgery, on average, patients are in the hospital for around 4 to 6 weeks, depending again on what's going on. During the first I'd say 4 to 6 months, you'll be in the DC area because we'll have to really closely monitor you. It can be a little strenuous, and eventually with time, things will, we won't be closely monitoring you all the time, but during those first months, it's very important. Following surgery, just to, I guess, some facts is you'll have a feeding tube in your stomach, and you'll also have an ileostomy. Okay. And so fortunately, by the time a majority of patients are actually going to be off of that TPN by the time they leave the hospital, which is very exciting for both the patient and I. But sometimes if patients haven't been eating for months or even years, it's kind of relearning to eat and to get that nutrition. So we put the tube in to help with nutritional support via like tube feeds. But again, eventually our goal is to get patients off of tube feeds and they get the tube removed, and then they're just eating and drinking fluids normally. During that time also, well, the light went out. Okay, I've been sitting too still. I won't get up and do a dance. Okay, so most of the time the line, can come out, the line will come out. And again, that's another opportunity that patients haven't had in quite a few years, to have no line, in their body. So no tube, no line. So the next part is the stoma. So in bowel transplant, we don't have a specific lab that will tell us if the bowel is rejecting. So what we have to do is we actually have to have close surveillance of that. So what we do in the initial, first 3 to 4 months is we're continuously doing a scope, which is, many patients may know of a colonoscopy. Again, it's an ileoscopy. Moved
There we go.
And we put the gastroenterologist will scope the patient's transplanted bowel to make sure there's no rejection or infection, so that we can catch those things very early on. Some patients, after that, we can actually reconnect the small intestine to the large intestine, to the colon, and either some patients will have, an end colostomy, or some patients are actually going to be reconnected to their rectum, and then they go to the bathroom normally. So I'll say the first 6 months can be very strenuous and rigorous, but then after that, a lot of patients, if they're from, say, Texas, they're making their way home around like the 4 to 5 month mark, and they might just have to come back periodically to see us. They'll still be required to, get labs and, period and, check in with us. I will say, fortunately, virtual visits are a thing now. The pro of COVID, if you could say, but it's been very helpful for me and for my patients who have been, all over the country, to actually physically see them. So that's great. And then I think, just to mention, you'll be on several medications after transplant. You'll have to take medications so that your organ doesn't reject, and also medications to prevent infections, because you will be immunocompromised.
Okay.
And then I think you mentioned like returning to like work or normalcy. So again, I think during the first 6 to 12 months, you can start getting back to like your normal life. And then patients will actually return to, if they were going to go to grad school or undergrad or even high school for our pediatric patients, or going back to work if that's what they were doing before. So we did do just a little fun fact too, is we did do a research study here, and we did find that our return to work rates for intestinal transplant patients were similar and comparable to liver and kidney transplant patients. So getting patients back to a more normal life is our goal.
Yeah. That's the main goal at the end of the day. And so, Katie, what's your life now like post-transplant, and what was your experience going through? Like Hannah said, the first 6 months are pretty rough. What was your experience going through that?
Well, my biggest hurdle, I think, was shortly after, like when I got home, because you get this lovely medication.
Oh, wow.
And that's what you have to get used to is taking your medication around the clock.
Yeah.
So that was my biggest hurdle, I think, was just trying to stay on top of everything. and it's because you have to take it on time every time. It's very, very important to take the medication at the exact same time every day. So that was, I think, my biggest issue getting out of the hospital. I was in there for 3 weeks, so getting out of the hospital, that was like my biggest issue. But after that, everything has been amazing. Like, to say the least, it's been amazing, and it's like a whole new I have a whole new chance at life. I almost had a bit of remorse or guilt, or I almost like a survivor's guilt, because I'm healthy, and to be healthy for not being healthy for a long time is it's different. It's really different, but it's the first 6 months was not as difficult as I thought it would be. They make it so easy. Everybody there is just, when you go for scope, the girls that are there, the nurses, they're absolutely amazing. It is a difficult, strenuous, a lot of appointments, the first 6 months, but you're doing it and you feel like you're at ease. It's not as strenuous as I really honestly thought it would be. And I feel great. So
Yeah,
I feel amazing.
That's great to hear. And yeah, I think that really shows how important it is, like, when you're going through things like this, the people that you surround yourself with, from your family and friends to your doctors, and they really make the difference, and like you said, made it a lot easier and on you. And so that's great to hear that you're doing well. And yeah, when you mentioned all your medications, I was just imagining like having a million alarms set on your phone, like going off like during the day and stuff.
Kind of is at first.
Yeah, yeah. So we did get 2 questions from our viewers. Our first one is from Gina, and she asks, what is going on these days for appendix cancer patients and small bowel transplant? Hannah, I believe you mentioned that appendix cancer could be one of the possible needs for a transplant.
Yeah. In general, I mean, I wouldn't want to specifically answer that question in regards to appendix cancer. So I would prefer to defer that, and then I can get back to you guys.
Okay. Yeah, sure. We will respond to your question in the comments, Gina. Thank you for asking. Our next one is from Karen, and she asks, what is the least invasive way to look for an internal bleed? Hemoglobin is half where it should be, and getting iron infusions now.
Most like least invasive way, I mean, it sounds like if someone's monitoring your hemoglobin, which it sounds like they are, if you haven't had, maybe you should see like a gastroenterologist. They may need to do like an upper scope and EGD to look into your esophagus and stomach, or possibly even a colonoscopy to look into your intestine to see if there's some kind of bleeding source from that.
Okay, great, thank you. And thank you for asking your questions, and everyone for tuning in. My last question for the both of you, so what we always like to end our broadcast with, is a nice little wrap up. What is the message the two of you would like for our viewers to take away after watching this? Hannah, I'll start with you.
I think that the main thing is that if this is the first time that you've heard of intestinal rehabilitation or transplant, you're certainly not alone. A lot of people and even providers aren't aware of these, life saving therapies. So if you or if someone is interested or has more questions about being evaluated for one of these programs, just please give us a call, and we're more than happy to see you.
Great, thank you. And Katie?
She couldn't have said it better. It's the truth. I didn't even know that having transplant was possible, especially for Crohn's disease. I was told that they don't do it for Crohn's disease, where I was in Nevada. Yeah. So just have hope and just keep going. Don't stop fighting. I kept fighting, and I found MedStar Georgetown. So just keep fighting, and keep reaching out and ask questions. And yeah, she said it better than I could have.
Well, that's great. Thank you. I think that, yeah, that's the message I had in my head too. So that was perfect. So yeah, that wraps up our broadcast. Thank you so much, Hannah and Katie, for joining us, and for all of our viewers for tuning in. For more information about MedStar Georgetown Transplant Institute, please call 202-444-1058. We'll also be sharing a link in the comments to a video that we did with Katie, if you want to hear more about her story. So thanks again, everyone, for joining, and we will see you next time.
Great, thank you.
Bye. Thank you.